All right. So, hi everyone. I'm Dr. Palvi from the Edinburgh Napier University, and I warmly welcome you all to today's webinar on rethinking healthcare leadership, global collaboration at the intersection of AI, well-being, and workforce sustainability, which is a BAM-funded project. Thank you all for joining today. It's great to see colleagues from different institutions, countries, and also different career stages here. This webinar is organized by the Research Development Committee of the UFHRD in collaboration with the Academy of Human Resource Development, and it reflects UFHRD's long-standing commitment to supporting research development and international collaboration within the HRD community. The the Research Development Committee basically supports and develops research in the field of human resource development. Its role includes organizing research seminars, webinars, supporting doctoral researchers, promoting collaborations, and also helping members develop publishable research and academic careers. The committee also tends to oversee research development initiatives and small research honoraria, supports the doctoral symposium at the annual UFHRD conference, contributes to research policy discussions, and also promotes the dissemination of HRD research through conference and journals such as the HRDI. For those who may be newer to the UFHRD, the forum has been working over 30 years as a supportive international member network, and the whole purpose is to promote HRD as a field of study and practice and to create, develop, and share leading education, research, and practice that advances individual and organizational knowledge. UFHRD provides opportunities for networking and collaboration through its annual conference, committee activities, and partnerships with other organizations, and it actively supports the dissemination of international research and practice through associated journals and other communication platforms. Through this webinar, we aim to provide insights into how leadership must evolve in response to AI and workforce pressures, create opportunities for global collaboration and shared learning, as well as put forth practical strategies for building resilient, sustainable healthcare systems. It is my pleasure to welcome our international panel. So I first would like to welcome Professor Julie Davis from the Brunel University of London, UK, and also the chair for the Research Development Committee, UFHRD, Dr. Kamal Gulati from AIMS, New Delhi, India, Stephen Callaghan, King Faisal Specialist Hospital and Research Center, Riyadh. Dr. Myra Malik could not make it today, but then I still extend her a warm hi from our end because she's part of the project. Han Liu from the National University Hospital, Singapore. With that, I'll now hand over to Julie, who will introduce us to the project, and then we hear from our speakers from, across all the countries, and to bring out the country perspective. So we'll go, the sequence would be Han, Stephen, Kamal, and then Julie. So over to you, Julie.
Yes, thank you very much, Palvi, and thank you everyone for joining us. We've got some practitioners and scholars from different parts of the world. So it's really a pleasure to run this workshop. So we really appreciate your feedback. We're at very early stages. We've just about got the ethics through and we're looking at the literature. So we haven't yet gone into the field to collect any data. So first of all, I guess I have to thank the British Academy of Management for funding this project. It's a transition project and it's until April 2027. And also we're pleased that it's UFHRD and AHRD, our American colleagues, working together, and we have a conference the 17th and 19th of July in York. So first I'll perhaps get at my co-collaborators to introduce themselves. So Han Liu from Singapore, where it's 9 o'clock in the evening. Would you like to introduce yourself?
Yep, hello, hi, morning, good afternoon, or good evening, depending where you are. Yes, my name is Han. You can call me Han. I'm a nurse by training and spent a year in the UK for a did an MBA, and currently my focus is driving innovations at National University Hospitals, one of the leading university hospitals in Singapore. So yeah, glad to be here. Thanks.
Great, thank you. Stephen Callaghan is another nurse.
Hello, everybody. My name's Stephen. Originally from the UK, worked in palliative care for the past 17, 18 years now. Currently in Saudi Arabia for the last 4 years and currently a PhD student at Lancaster University. Pleasure to meet everybody.
Great, thank you. I'm from India. Kamal Gulati.
Yeah, hi, good evening. My name is Kamal Gulati and I work at the All India Institute of Medical Sciences, New Delhi. I am a Shivning Fellow, spent some time at Oxford. I work very closely with Professor Julie Davis at Brunel, and my area of interest is medical leadership. And I'm now focusing on the gender and well-being burnout part of the healthcare workforce. So look forward to your feedback to how we can take this study forward. And I'm sure that your feedback will be valuable to improve our work and bring some meaningful outcome from this. Thank you.
Great, thank you. And Dr. Mara Malik is an anaesthetist. She's a consultant in the local hospital, Hillingdon Hospitals, very close to Brunel, University of London. So I'm from a business school, and it's really exciting working with people from medical schools and other parts of the world. So I guess the question I'd pose to you really, to kind of contextualize the motivation for this, is how do you feel about the health of the people who treat you? So there's this concept, when I first look at the director of workforce at WHO, I wondered why he had HRH after his surname, because that means Royal Highness. But it actually means human resources for health. So how well are the people treating you? And a question we had in our discussion was, would you like to be in Xinhua, perhaps at a hospital in China where you'll get treated just by a robot? Would you like a combination of the two, an expert C who uses AI, or someone who doesn't use AI at all? And do you even know how much AI your healthcare practitioner is using? So feel free to put in the chat A, B, or C. Feel free to do that now. Get some audience participation. Great. As expected, unanimously, it's C, although Jim, and Jim, you preferred to differ as well as John. Jim, any thoughts?
Well, I've recently, in the last couple of years, experienced care by a person, both for myself and my wife. Yeah, that's why I prefer a person, I think.
On their own, without
On
AI
their own,
intervention.
Yeah.
Yeah. Okay, so your concerns may be echoed by MIT's study here. On the left, you've got someone who uses ChatGPT, whose synapses seem to be distinctly not connecting, and on the right, without ChatGPT. So we can overuse this clearly, as I think we're finding in higher education. And on the circuit at the moment is this Egyptian guy, Mo Gaudat, who's brought out this documentary that's doing the rounds in cinemas here. And he's actually asking this question, are we in an Oppenheimer moment? So when they discovered nuclear fusion, made advances in science, they can use it for evil, for nuclear bombs, or for good. And his son died in an appendix operation. And he's questioning really the ethics of AI. So he formerly worked for Google, this kind of moonshot factory, and he's asking this question that I guess underpins our study. How can we reap the benefits and tell positive stories of healthcare workers using AI for their own well-being and our well-being? And what really are the dangers? So this Chasing Utopia movie seems to be hot at the moment. So what we're going to do, I suffer from concept overload, so I noticed Damien is on the call here. So I appreciate any inputs on how to simplify our theoretical view of this project. So we're going to give you some kind of background, what's the literature saying, look particularly at this job demands resources theory and how we can update it and contribute. We've also got a little bit of reflexivity about ourselves as a research team and looking at the literature on that. And then each of us in reverse alphabetical order or slightly reverse alphabetical order is going to give a little bit of insight into our own context. So I do wonder, doing this project, whether it's almost like doing a project on e-commerce or oxygen. It's like this is obvious, we'll all be using this eventually anyway. So why do we need a particular study on this? But clearly at the moment, it's an emerging technology. There's AI for clinical purposes, AI for admin. So there's lots of different types of AI. And I think in this sector, it's not a concern in terms of just people losing their jobs and replacing people with robots. There are real issues about burnout. There are issues about involving people on the front line in implementing AI, and there are very clear regulatory issues about ethics and trust. And a key word that appeared, we had a conference at the end of the year in Saudi, was about validation. How do you validate the information you're given? And how do healthcare practitioners work with AI coders and the issues of algorithmic bias? Particularly, we know a lot in terms of women's medicine is under-researched. So we've got these chronic workforce shortages. The Iran war has exacerbated the cost of living, and clearly in lots of parts of the world, particularly, well, I guess Singapore and the UK, people are getting older. So we are looking at AI as both a resource and a demand. So there's a kind of duality to this technology, and looking at how this is impacting not just on day-to-day jobs, but the leaders who may be older than some of the people using this technology, and so there are intergenerational differences, and how is this impacting people's careers. So there's a lot of concern at the moment about graduate employment and people not finding jobs. So we're really seeing this as something that is an enabler and a facilitator, but in the wrong hands can be highly dangerous in a safety critical industry. So from an HRD perspective, what are the kind of dynamics in terms of adult learning, leadership capabilities, and just ensuring people are thriving in the workplace using this technology? So we're looking at how AI can be both a demand, for example, in terms of techno stress, and also a tremendous resource in clearing out admin nonsense that people have to deal with, these repetitive tasks, and what this is doing in terms of our traditional models that we have. So I think we're all familiar with this quote that was from 2023, AI won't replace you, it'll just replace people who don't use AI. But there is the danger that we're losing our own intelligence because we're replacing it with AI. So only yesterday, Princeton announced that it's going to have real exams, proctored exams at the university now, because they just can't deal with their previous assessment. Sweden realizes it's going down in the rankings in terms of PISA and education. So actually they're bringing books back into the classroom, and our pilots are bringing back, methods to fly without GPS. So how do we make sure we don't lose our own intelligence and replace it with artificial intelligence? And there's various studies like this, people may be more productive using AI, but they're less motivated. So we had a discussion, there are lots of forms of AI, and I think actually asking people how they use AI in their own personal lives is also interesting, and how they bring that into the workplace. So is it facial technology? What are people using? We've got guidance from the EU on the benefits of AI. Mostly this emphasizes efficiencies and costs. And then this is Mental Health Week, I think, and we've seen the real dangers of suicides and awful things happening as a result of AI. So there's artificial generative AI, there's super intelligence AI coming towards us, and all these tools. China massively far ahead in many ways with these robotic hospitals, issues of these huge companies stealing our data potentially, and physical AI. I've seen in Japan how robots can help the aging workforce. So all these different tools available, and how do we make sense of them, while we've hardly got any bandwidth to learn new things. So if people are hugely burnt out like this because they're disengaged from work, they have no energy, and they're not flourishing, how on earth do we assume they're going to take on new activities while they're, hardly capable of doing the day job? So how do we improve satisfaction and meaning in the workplace, as well as emotional aspects? So there's kind of 9 aspects of well-being, beyond just emotional, cognitive, and physical. And what is going on in the career ecosystem? We haven't really seen any job descriptions that talk about AI in normal jobs. Clearly, there are new jobs emerging, like Chief Technology Officer, Chief AI Officer. We see that in academia as well, people having AI in their titles. So there are also issues for identity. If you're a physician or a nurse or another practitioner who spent years gaining expertise, only for that to be reshaped and replaced by technology, and how are you going to develop AI literacy? And one of the key issues, obviously, we're waiting for regulation, certainly in the UK context. So we're going to be 18 million healthcare worker short in 4 years' time. And so we've tried to justify, why we've got these 4 countries. We've got 2 islands, 2 very large countries, India and Saudi Arabia, with young populations. So we're going to have to work through this, other than we just serendipitously brought each other in. And obviously there's a lot of great literature on workforce and AI. So there doesn't seem to be a lot about leadership at the moment. There's this paper about the importance of understanding external conditions as leaders and partnerships, particularly with AI coders, having internal capacity when people are overstretched already, and what is this doing to professions? So I guess at AIMS Delhi, and I guess Brunel, we have medical schools. What exactly are we doing in the medical school curriculum? And then, what kind of leadership do you need? So this Forbes article last month was talking about a leader as a lighthouse, shining light, but not actually knowing necessarily the way to go themselves. And then we had all these prophecies from these tech giants, Hinton and Musk, predicting that there would be no radiologists by 2021. We wouldn't need to drive our own cars by 2017. And clearly none of that has been fulfilled. And we've got huge shortages of radiologists. So to bring it to HRD, there are various papers here we've discovered in the literature looking at technical systems and social systems, bringing the 2 together with literacy training, workflow design, feedback loops. And the third element here is the ethical system. So the technical system, the social system, and the ethical system. And for the time being, before we go and collect our data, we focused on this JDR well-established model, looking at demands in the workplace and resources like autonomy, training and support, feedback that can help people deal with shortages of resources or feeling overwhelmed. And I think what we'd really like to do is find positive stories. There's plenty of doom out there. But how can, looking at this theory, help understand AI that is a socio-technical actor that brings together changes in professional identity, well-being, and performance, and not perhaps the old way of looking at burnout and JDR as like separate categories. So we've got what is missing maybe from this model is the sense of context. So we've got different national contexts, policies, infrastructures, and so on. And I guess when you have a project, 1 minute you think there's nothing out there, and then suddenly you find 2 papers that have actually answered your question. So thanks to this webinar, we found a very recent paper in Frontiers that did look at physicians and their well-being and how AI is affecting it. And their findings were that if you have resources that support autonomy, innovation, and resilience, then people can do much better with AI. And this excellent paper by Zaha et al., they looked at the kinds of resources, the competencies needed by healthcare workers using AI, such as AI fluency, responsible leadership, relationships. So in the bottom left, you've got the resources, and the top left, you've got the various roles that physicians play. So actually unpacking that model is really helpful, I think, for our study. And ethics is very important. Workflow, data, stewards of data, and then the demands are sort of typical that we've seen in the past. And there's lots of like McKinsey and other people shunting stuff out like that. So of course, there are some papers that say AI is brilliant. It enhances job satisfaction. So this paper from China gives people more sense of autonomy when jobs are complex. Here's another paper. It's great to get rid of the admin. So you can spend less time staring at screens and talking to patients. But this element of caution is still out there. People are worried. This other paper said it was actually very unhelpful. So the more radiologists used AI, the more anxious they became. And there's a lot of rhetoric, hype. So I went to Seattle recently. I sat next to a guy who was going to an Amazon strategy workshop on the future of Amazon and so on. And he reckoned this AI bubble is going to blow up, certainly investment in AI in the next 2 years, if you're investing in this stuff. But disappointing returns, a lot of anxiety, and a lot of people are worried, according to this study from Harvard, that AI is just making them dumber. 44% feel it's making them dumber. And 54% feel it's impacting on the way they connect with other people. But 61% said that using AI to help with my work will make colleagues question my personal competency. So it is making people question their own identities and their capabilities. Why AI will not outsmart complex knowledge work. This is quite an old paper 7 years ago from Wes, but it was arguing basically, if you're doing complex work that involves judgment, relationships, and an understanding of context, AI can't necessarily replace that. There is an issue of low actual use, fear, but I think looking at GPs in the UK, increasingly there was this survey, The Guardian reported on it, from taboo to tool. The government is mandating things like ambient voice technology and AI scribe, and that is becoming just a norm at the moment now. So it's like people, once scared of looking at Google, now everybody's using it. So it can be transformative, according to other studies. It does improve work life and efficiency, and helps in accurate decision making, better time management, and it gets rid of really of the dross. But the real problem is that we just over rely on it and switch off. This was on CNN on a podcast I saw the other day. So Robert Wachter has looked at exactly what we're looking at, and again, issues of trust, privacy. But he says now he sees medics going on rounds, and before they go on their ward rounds, everybody is looking at open evidence. So this is a peer-reviewed literature site where you can find useful information. So he said it's just becoming the norm. Medics aren't embarrassed to use this anymore. So how do you build up healthy habits? And clearly, if people, come with chest pains and shortness of breath, you don't just sit around consulting your AI. You say, get to hospital straight away. There's sometimes when you just abandon it. So that's an interesting book. Another book that's come out by Fateh Mehmet Gul also makes similar arguments. It's fine to replace paperwork, but not physicians. It's great to help people who feel overwhelmed, and patients don't feel seen at the moment. So hopefully this will help you look your patients in the eye and actually focus on them and not just technology, but access, equity still matters. And it's all about caring. So we need to keep that. And then finally, by this surgeon in London, Shafi Ahmed, he's also written this book about intelligence, artificial intelligence. And again, you need to keep the human side. So there's quite a lot about leadership in this book, and leaders becoming orchestrators, not just controllers, keeping the human side, the relationships, helping with staffing models, workflows, making things more human, ensuring equity, equality, huge problems with medical legal issues. So I guess we'll see lawsuits about why you did or did not use AI. And he says these are the questions we should be asking. You know, what problems are we really trying to solve? And how can success be measured? And the importance of, you know, talking across groups, so multidisciplinary teams, and bringing these AI scientists, who are often men, actually, you know, into the conversation. And I think this point that we don't talk about enough maybe is joy. So, you know, how can we get pleasure and flourishing in work? And it's not just about, people don't just come to work to be more productive, but how do you actually enjoy your work? I think we forget that in the conversation. So he says we're moving from models of hierarchy, control, and being reactive to adaptive, orchestrating, and networking. And it goes on and on. Myra's given me these slides, so I'm feeling a little bit lost in these slides. So we have the positive side of, you know, the opportunities on the left, and then how things could actually get worse on the right. So we need AI-enabled education at scale. That's what he's arguing for. Okay, so clearly ethics are a challenge, and governance we need to unpack when we're interviewing people over the next few months. Where are the safeguards in all of this? We're looking for a consultation exercise to be finished in this country. The lawyers, where are they in all of this? And ironically, as I said, we're kind of going back to pencil and paper. So in Venezuela, I think here this talks about, and the Ukraine, increasingly there's hallucinations. These poor pilots don't know what's real and what's not real. So they're going back to previous ways of flying. The problem is, I've discussed with Myra, you know, some of the new healthcare practitioners coming into the system, they only know AI. They only know robotics. They only know how to use technology. So if Google goes down, the internet goes down, you don't have access to electronic patient records, can these people actually cope? So I think, Pavi, we're talking about your son moving from Indian education to UK, and actually, you know, writing with a pen actually, you know, makes you learn better than working on a laptop or you know, an iPad. So this is an issue. Plane jamming, somebody turns off Starlink, and so on. All right, so that's the context. Methodology, we're aiming for at least 20 semi-structured interviews in each country. So now at the moment we're trying to kind of coordinate what questions we're asking, and what theory we're going to focus on, which may change depending on feedback. And then just looking at our own, you know, are we using AI ourselves? I don't think we are, actually. So how do we build that into the team? And clearly we've got non-Western contexts, which are always missing in the literature. And at the moment, we've got concept overload. So how can we aim for a good quality paper? We're getting much more clearer in terms of conceptual thinking and so on. And impact, that is always the elusive thing. So certainly Steve Callahan on this call, you know, at the coal face is fantastic that we can actually change things, policies and practices I've seen at King Faisal because of our research. It's really exciting. Hopefully we can do that in Hillingdon and other places. So we did take a little bit of time, I guess, you know, when you do your methodology section, it's good to think of researcher reflexivity. So we've found 2 papers that have really asked us to think a bit more carefully about how do we work across cultures, different languages, you know, even our Harvard referencing is different from medical school referencing. And so what cultural assumptions are we making in different healthcare contexts to have a kind of joint project, really? So we may assume things that actually are not the case in a very hierarchical context like Saudi and India particularly, and our own biases. I think most of the interviews will be conducted in English. And how on earth can we compare, you know, a small country like Singapore and England with a huge country with 1.4 billion people, India and Saudi as well. So there are sort of very practical challenges for us as well that we found out with ethics. And we do have diversity in the group, which is great. And, you know, looking for outlets to publish would be interesting. Okay, so I think enough of me. And now I'd like to move over to Han. Unless there's any questions, any immediate comments or questions that anyone would ask, like to feedback on all of that. John?
Quick clarification. What's an AI coder?
So I guess someone who actually creates the ChatGPT or the facial recognition software. So yeah, I had a story, someone at UCLH, who's an orthopedic surgeon, he said that the technology people bought them all iPads, so they didn't have to use x-rays printed. And they didn't realize that the thing turned off every 5 minutes or after 15 minutes. So they're in the middle of operating using the x-rays, and then the iPad kept switching off. So there was no kind of communication between, you know, the tech people and the surgeons. And they actually had to employ a nurse just to wiggle the mouse for a year on this machine or something to keep the x-rays live. So, you know, you build in algorithms for white men and you're treating ethnic minority children.
Yeah, I get that. And equally, in terms of the ethics side and the safeguards, what are your thoughts at the moment in terms of the types of ethics and so forth that should be influencing the project?
What, in terms of Kant or deontological or ethics of care? I mean,
well, mainly not making assumptions that a certain type of ethical approach is appropriate. I guess that's what I'm trying to think. We would say that humans are, or the human contact is important because we deal about human resource development. But you've just given a lovely example there of where somebody clearly forgot about the human side. So I'm just interested to understand how you're going to overcome your assumptions on ethics and ethical approaches that may be appropriate for AI.
Yeah, Stephen, are you there? Stephen on the call.
I'm here, Julie. Hello, I'm here.
Yes, hi. He's a great person for ethics.
Sorry,
because end of life care is like a serious
if I turn off
issue.
My camera, it's just usually means that the signal at the moment is quite bad.
Yeah, that's fine. I know you're in Prague. Yeah, go ahead.
Sorry, can you say that again, Julie?
So ethical issues and AI.
Yeah, so I can speak for Saudi Arabia. So the ethical issues is so I can give you a live example at the moment from our hospital in Riyadh. They have now banned all kind of patient relation information to be put through an AI system because it relates back to the ethics of that patient. So what sometimes we were doing is we were putting in the medical diagnosis, the age and things like that of the patient through in a ChatGPT or Copilot, and they've stopped us from doing that now based on the fact of ethics, because the patient's data is now being put out to the world. Even though you're not naming the patient, they're saying that you could technically relate it back to the patient in some way. So until my hospital have their own version of, or a licensed ChatGPT or something to confine the results, we can't use any AI at the moment with patient related information. So that is a live ethics problem at the moment, which I was against completely. But when I looked into it, actually, if someone out there really wanted to look into that, you could say, it was a white male, 46, have this and that from the UK. It wouldn't be too many people based at that hospital under them. You could really find out who. So ethics in AI originally wasn't being looked at too much because they thought it was a harmless tool that you can just get information from. But when you're in Saudi Arabia in the desert and you've only got one nurse or one doctor and you need advice quickly, sometimes you're sort of pushed to use an AI tool to put the information in, but now they're stopping that. So what was once brilliant, these brilliant tools can give you the answer. they're now restricting them because your patient's data are being put out to the world. So that's a live case. It's a problem. One that we didn't really look at, Julie, to be honest with you. Maybe, you know, with our questions for these interviews, maybe we can put something in there like, you know, like do you feel that you know, you could be breaching data with your patients by putting this into, unless you change the whole makeup of the patient, but then you may get a different answer from AI, the one that's going to help you. You need to be specific with AI, right? This is the thing.
Yeah, I think Mara said that everybody's putting in, you know, patient X is presented with ABC and not naming them. And then they're saying, you know, you really shouldn't be doing that. I mean, I know people who work in government, they have, I think in the Cabinet Office in the UK, they have something called the red box. So they have their own version of ChatGPT that's a closed version.
Yeah.
Yeah.
Does that answer your, I mean, Julie, does that answer your question? I mean,
John,
it was one thing that we never really took it into consideration when we first got going, to be honest with you.
I think what we have considered is formal and informal. So at the moment, there's a lot of informal stuff going on. You probably say to your students, don't use ChatGPT for the exact question, but informally they do all the time. So that's the trouble. Yeah. When it's an immature technology. I mean, other places now it's almost like mandated, you know, ambient voice technology for GPs in this country. Okay,
Great.
so
Thank you.
if we can transport ourselves to Singapore, very nice, neat nation state.
Thanks, Julie. Yeah, thanks, Julie, for setting up the scene. So again, once again, I'm Han. I'll be sharing with you some insight from Singapore. Right, maybe next slide. Okay. All right. So what I'm going to share today will be more for the people and well-being, especially in the healthcare. Again, this was launched in 2023, December, under Singapore National's AI Strategy 2.0. Stands for the second versions, right? So essentially, they are positioning AI as a national capabilities. As you can see on the picture on the right here, it actually simply shows that healthcare and biomedicine is being identified as one of the key domains of excellence, as it sits in between the leading economy sectors as well as the smart nation's priority. So the rest of the industry, you will see that they would have fintech, educations, logistic, so on and so forth. But health and biomed, it sits right in between these two. So what essentially this National AI Strategy 2.0 emphasizes is that it's not just about speed or skills anymore, but we are now taking a more systemic approach in terms of governance, infrastructure, people, and trust. So all have to move in all together in a whole ecosystem view. And I guess that brings us to the important questions about how do we adopt AI in a way that strengthens our workforce instead of just pushing out the throat and making, you know, the staff on the ground more exhausting. So I mean, it doesn't also tell us that what happens, right, inside a nurse or doctor's minds when an AI starts making triad recommendations, yet it does not have that kind of explainability. It doesn't tell the doctors or make a nurse feel more empowered, but yet the algorithm sometimes can actually outperform the clinical intuitions. But then how do you then strike the balance in between? I guess then the workforce everywhere in the world is really facing not only shortage, but more for systemic pressure. And right now, I guess we are now at a moment while we want to accelerate the AI deployment across institutions. How do we then acknowledge the well-being of our healthcare staff? So next one shares by an article shared by from Grey Literatures that argues that while our organization racing into the AI adoptions, we are actually accumulating what we call the psychological debt. While the leaders in organizations looking at technical skills or looking for return on investment, but one thing that we might be missing out would be the psychological debt, which ignores and it can be compound quietly into our workforces. So what this article essentially says about there are 6 debt that was identified. I'll just quickly run through each of them. So first will be the cognitive debt, that it simply means that AI does the thinking and the clinician will then stop practicing. Hence, there will be always a risk of de-skillings. So just one of the example would be a radiologist used to scrutinize every corner of a scans. while a very well-trained AI or large language models put it in place, 6 months down the road, the radiologist actually, might be losing the skills of interpreting the AI, and all he did was just focusing on AI outputs. And the next one will be the autonomy that where AI sets a pathway and clinician just follows. The third one will be competency gap. So I think this will be more on the erosions of confidence of clinicians when he or she is performing certain skills. So one example could be a junior doctor was trained to read ECG, finds that AI has actually rendered its outcome before she finished looking it. So over the months, she can just stop practicing the skills independently, right? And just think about one day if the system is down, when there's downtime, she probably took longer times to interpret the ECG because the AI is no longer helping him or her at that point of time. So I think that's where the competency depth will start gaining when we deploy AI across this without acknowledging this. So next one will be the relatedness, more across talking about social isolations. I guess this part is what was being mentioned, where when we have AI in place, are we spending more time in front of a screen instead of communicating, talking to patients? So I guess one example would be while AI can summarize patients' past medical history, social history, are we then losing that moment, right? Communicating with the patients, spending time talking to the patients, while AI can just through one click summarize, he can just summarize within seconds. I guess that also in healthcare, particularly when we always believe that empathy is something that within us, but with AI coming in, relatedness depth is always a risk there. The next one will be credibility. I think this happens when you can't really explain the AI reasoning to a patient. I think in the technical terms, this will be more on the explainability of certain AI outputs. So think of an example is that while the pharmacist is challenged by a patient, that, hey, why did this system flag this out? But the previous doctor says that this medication is fine. But then when the AI was being designed, it did not tell the pharmacist that why was the AI being come up with these decisions, right? Based on what are the source of informations. So if there's no such explainability to the pharmacist just couldn't explain why did the system flag out these particular medications, right? I think at a point of time in that particular situations, in the eye of a patient, the machine seems to have more authority than the pharmacist does. So I think that's about the credibility in terms of the professional devaluations. The last but not least would be the identities, right? So if a senior consultant spends 20 over years to become a senior consultant, but now with AI, through one click, you're giving also social information, sign and symptom, lab tests and result. The AI could probably give you some diagnosis if you give a proper prompt, right? So now what makes a medical doctor's difference, right, when it comes to consultations? Of course, the robotic surgery coming in place, but not so soon, although there's already in place. But yeah, I guess what we are trying to say here is the psychological depth, right? Here is the mental model that we're looking at. Every time when we deploy the AI without considering its impact on the human use, we are actually taking out a loan. Though through a short-term gains, well, I mean, in-house, we still measure how many hours we save per year, per month. We get through the speed, we measure productivity. But such interest in terms of our psychological depth, they actually compounds quietly. And then while the articles draw from different insights from different hospitals, so then we might ask, right, is this really happening in Singapore, or right in our own hospital and polyclinic? Well, a team actually asked the same questions. While in a community practice, they found that workforce burnout is not an abstract risk, but it is already in place, right? But here, the key message here is just that the last part where nearly 1 in 10 workers in Singapore in the primary settings actually has the intentions to leave their position within the next 6 months. And they are actually actively planning to leaving it from this research. And what the study actually shows that interventions are actually focusing more on system level changes, optimizing team-based care, improving patients' provider recognition loop, rather than relying individual coping strategy. So on the right, just on this slide. So I guess from this slide, more from if you look into the first article, talks about the 6 psychological depth, and drawing from the 3 burnout domain that measured in locally Singapore, we can see that drawing from a job demand resource model, AI can be a demand, yet it can be a resources at the same time. While they are not, while we are deploying the AI, there's always a risk that we have to acknowledge. I guess then in this particular research, we are asking ourselves that while we are deploying AI in such a large scale to align our national priority, are we then losing out the well-being of our workforce? Right. So yeah, I guess that's what we are trying to say, is that the well-being of our healthcare workforce should be considered when we are deploying AI.
Comments, questions anyone would like to make on Singapore or those observations? All right, so let's move on. Thank you very much, Han. Stephen, you with us? Yeah.
I am. Hello. So everybody, so what I done originally was looked at the kind of literature that's already based in Saudi Arabia. I'm not sure if anyone's aware, but Saudi have got a very ambitious 2030 vision, which involves a lot of things, but mainly is to transform the health sector. And see, originally with Saudi Arabia, they relied very, very heavily on an expat workforce to bring their expertise to Saudi Arabia. Now they've kind of got very, very ambitious, and it seems to be working quite well. We're relying less on expat workforce and kind of strengthening their own kind of like Saudi workforce, getting people into work, higher education. That's why you see a lot of Saudi Arabian nationals studying abroad. But there's only one problem with that, with the aspect of getting people into work and getting, lots of people their jobs. There is a fear at the moment that actually AI is sort of being, with it being part of their jobs, hence why we're doing this research. There is a bit of an uncertainty that I don't think Saudi Vision 2030 really, addressed when it was, I think it was done like 6 or 7 years ago that this vision was implemented. They didn't look into the AI aspect of it. I mean, it was addressed, but not to the point of it replacing jobs. But as you can see, this is what I found, as you can see on the list here. The Ministry of Health in Saudi Arabia endorse artificial intelligence. They adopt it. They actually say to us, as part of our role, please use AI in your kind of education. Obviously, don't take it don't take it and put it into your own work sort of thing, but use it as a good reference source. Until recently, where it says anything patient related cannot be put into an AI search engine. But the key insight here is they say it's central. It's endorsed by the government. It's central. It's important because a lot of Saudi Arabia is in hard to reach areas. It's a very, very, very big country. And they say AI is essential to getting the kind of healthcare to these people that are hard to reach in, mostly in the desert. Because in my area, palliative care is only available in a very few cities in Saudi Arabia. So we do a lot of consultation calls for people that are hundreds of miles away. And again, seems to be a problem because we're being told to limit on what we're saying on, kind of like platforms, talking about patient information, unless it's coded by our hospital and protected by our hospital. Julie, can I have the next slide? Yeah, so I looked again at the actual literature. I think the last page was the grey literature. This is the actual studies. There has been studies done in Saudi Arabia looking at the use of AI. There is a lot of awareness, very significant, improves patient outcomes. It says the benefits are very, very good. But it does say, as you can see, for the fourth one down, they did find job insecurity. People actually fed back in nursing specifically that they fear for their jobs, because right now in some of the clinics in my hospital where you have the patients coming in, for example, when they used to go and see a nurse and the nurse to do their vital signs, now they're getting sort of you're having to check yourself in with your hospital number. You put your arm into some sort of, I can't describe it, some sort of machine. It does your blood pressure for you and it does your pulse and everything for you, and one nurse has to monitor 10 to 15 people's vital signs simultaneously. So whereas before you'd have one person, you take your vital signs. Now it's done automatically with a one nurse looking at the screen, seeing for any abnormalities. Now I'm not sure how effective this is, but they do say it's quite effective. But the education and training needs to be adapted, needs to be more rolled out, because I wouldn't feel comfortable personally looking at a screen with 15 people's vital signs and then having to very, very quickly say, yes, that's okay. Because number one, someone with higher blood pressure, which is, I don't know, 150 over 90, that may be higher to someone, but it may not be higher to another one. How are you going to interpret that quick enough? Because the machine can't do it for you, because we can't put that data in the machine right now because it's not been set up to do that. And also there's a trust. A lot of the studies were looking at trust, especially with a lot of our doctors, which is ultimately with nurses and doctors, doctors ultimately have, it's the decision with the rest with the doctors about the real treatment plan. Do you trust a tool that's you're going to take that advice and you're going to put your PIN number, whatever you want to put on the line based on a machine? That's the feedback I'm hearing from a lot of my colleagues. A lot of my colleagues will get an idea, but they'll use their own clinical judgment to put the plan in place. That's what I'm hearing back at the moment. And there is a worry, especially in palliative care where I am, that actually AI is going to be so rolled out that actually once the hospital do, because Saudi Arabia, as we know, it's got a wealth of money, and once they do roll out, actually there's an AI system that we can put the patient detail in that's protected. How many nurses and doctors do you actually need to roll out a plan that's going to give you it anyway? Next slide, Julie. Slide. So again, this is just, AI-driven healthcare. There's very clear evidence that AI is a very effective. It's coming in. The well-being burnout is a very, very big word. In what sense? Burnout and stress. So the two physicians I spoke to in Saudi Arabia, the stress aspect of AI is trusting the AI to give them the result that's going to be effective, because when you ask a machine something, you can't go back to the machine and tell them you're wrong and hold them accountable. That was what got me when that sentence, what he said, you can't hold the machine accountable for your actions. This is the thing. So there is a lot of burnout with it, because I think people are burnt out because they're trying to understand something that's happened very, very quickly. I mean, a few years ago we heard of AI, but now we're expecting to use AI quite a lot in our actual work. Can I have the next one, Julie? Q. So again, Julie's mentioned a lot of this. How we're going to look into this, we're going to do semi-structured interviews. We're going to be looking at doctors and nurses. We're going to be doing qualitative interviews. Now, the questions have already been agreed with everybody. So the question is again, Julie said that what's worrying me personally is how are we going to analyze data from 4 different countries that in their dynamics are very, very different. India is absolutely huge compared to Saudi Arabia, and Saudi Arabia is absolutely huge in the Middle East. And the UK seems to be very, very small compared to Saudi Arabia, but a lot bigger than Singapore. How do you go about? That's where Professor Julie comes in, I suppose, and her expertise, because I think these things have been done, but maybe not on the magnitude of what we're doing here. And I think it's going to be a question of bias as well, because I think that how we're going to analyze it. Does each person analyze their own results? Or, as someone said to me, Stephen, why don't you analyze, why don't I analyze Singapore? Singapore can analyze Saudi Arabia to take a little bit of the bias away. But then do you lose the richness of the because Han will know the Singapore, he will know the content of what they're saying, which the terminology I may not know. So then again, you have to look at these things as well. Julie, last slide. Oh, that's it. That's it. So I hope that made sense. That overall there is literature, grey literature and traditional literature. There is literature, but it does look at the aspect of stress, burnout. They do exist. But in Saudi Arabia, it's never been put under a microscope of semi-structured interviews. It's never been put under a qualitative lens where you've actually got these people in a room to a bit more depth than a survey and ask them the in-depth questions. But again, that main question, again, Julie says we've already got into is how do you analyze across 4 countries, different in size, different religions, different backgrounds, different cultures, and try and come up with one answer? Or do you come up with multiple answers based on a different country? That I don't really know what we're going to do on that one yet. Hope that was okay, everybody.
Okay, great. Apurva has a question. Go ahead.
Sorry, I was on mute. Good evening, good morning, all, depending on wherever you are. So great to see you, Professor Julie, back. Stephen, I have one question for you. And I have not gone through the entire policy that has been rolled out, but how strongly do you think is AI embedded in physician or nurses or clinical staff from day-to-day perspective? Because most of the nations that are on this forum, it is always the tech is always considered separate, and that is where AI and technical and coders will come in. And then physicians generally don't care. They only come at the last end where they're users of that tech. So if I have to compare apple to apple, I would like to compare and say, okay, this is the healthcare innovation happening because of the AI embedment. And then I will start looking at how. So if you can highlight that and talk a little bit about it, that will be very helpful.
Sure. I mean, yeah. So I think that what's happened, how to get the words out properly, I think the practice has happened before policy. I think people have acted and used AI before the policy have taken hold. I think it's a bit like the example I can use, COVID happened and the vaccine come. I think it really does work well, AI, but I'm guilty of it, and we've all had to be honest that we've all used AI, put patient information in. There was no policy in place to say we couldn't, so we were all using it. Physicians use it very much where I work. They really, I wouldn't say they rely on it fully, but they use it to back up their own clinical judgment. But the problem is with that, to back up your clinical judgment, you have to be very specific on what your judgment is. So, for example, if you're looking at a patient with a lesion and you think it's probable skin cancer, as we know, most people who are kind of dark complexion are at risk of skin cancer, but you have to be specific on the color and the gender of that person, the background of that person to you to get a response that's going to be helping you in your clinical judgment. So the policy is now forming. There is guidance in place from the government, but as it happens at my hospital, there is not a rush, but there is a push now quickly to get a policy in place that stops these things from happening. They want to create their own system where we can use AI for patient-related information that's protected and it won't be seen by the world. So the policies are coming after the practice. Does that make sense? That's what's happening at the moment.
It makes sense, but Stephen, in case there is a misdiagnosis and, for example, AI leads a physician to come at a different conclusion, is there any guardrails as to who will be held responsible? Will it be the AI vendor? Because in the US, I saw a case where there were some denials and claims, and the AI software was kind of not giving the right result. So, is there any guardrails around it?
Do you know, that's a very good question. I've not heard of any cases so far that have actually, but I suppose that's a good question for the physicians we have here. I mean, if there's any, there's a few, but what do you say, for example, if someone was, say, if one of my consultants was to put in AI, a specific diagnosis and it come out to be wrong. First of all, she's not meant to be using that platform to do what he's doing. So then he has to admit that he's gone not even off policy because there isn't one at the moment, you know. So I've got a feeling that actually you can't sort of turn around and say the computer advised me wrongly. Because then what you're going to say, Mr. Patel, what you're going to say is actually you don't need me here, you need the machine. So what they're going to say is I made a mistake. And you know, physicians, nurses, we all make mistakes. And what they do endorse is put your hands up. So you've made a mistake and we'll move on. But I've not heard anybody yet saying AI advised me wrongly. I think that will come, but I've not heard it yet. One of my colleagues actually that works in the UAE, she's a lovely, lovely lady, but she actually said, Stephen, you know, AI have really set me up. I said, in what way? They said, you know, look, I asked them to convert a morphine infusion and it gave me a point wrong. So instead of giving 10 milligrams, it said 100. And luckily she knew the big difference between the two, but that would have been disastrous for her if she would have gone by that advice. So answer your question, I've not heard of anyone blaming AI yet, but I think it will happen. I think it's going to start happening. Yeah, I think so.
Halvey, thank you. So medical negligence, I guess, is a big issue, and I'm sure we'll see lawsuits in America probably before we do in Saudi. And medical devices regulating AI is different process as well. Go ahead.
Yeah, I'm just thinking from a cultural perspective that, you know, the kind of nations that you've chosen for the particular study. I was just thinking if you tend to introduce the Hofstede's model and think about, I think uncertainty avoidance would be an appropriate lens to look at for this particular study because, you know, for all of these, you know, nations, the level of uncertainty avoidance would be high or low depending upon on the nation. So you may want to introduce, I'm assuming, you know, it might just be when you look at the results, you may have to justify your findings with regards to that cultural perspective that you may want to draw in. So Hofstede's model could be a suggestion to look at, especially the uncertainty avoidance, you know, lens may just turn out to be useful here.
Yeah, I think that's really useful. The uncertainty avoidance, people want certainty, and medicine isn't necessarily about certainty.
Yeah.
And also the hierarchical relation, patient-doctor, you know, would they sue you at AIMS? Probably not,
Yeah.
but, and they probably would in the States more readily. Yeah.
Yeah. So
Nice.
yeah, maybe the uncertainty avoidance or the collectivist, you know, the individualistic approach that you know, people tend to have. So that might just you know, provide some support for your findings. I'm just assuming the cultural aspect, which it might be a bit useful to take care of here.
And then the expats brings in complications between providers and receivers of care in Saudi when we've got different religions, and maybe in some ways India might be more homogenous in some aspects but not others. Great. Okay, thank you. So Kamal, you want to show your slides from your end?
Yeah, I'll just try to share my screen. If it doesn't happen, then I will.
Or I can show them if necessary, but I know you can't see them.
Yeah, I'm
that's
just
fine. Yeah, we can
yeah,
see
can you see it?
Yeah, if you can go to slideshow, that's fine.
Yeah. Is it slideshow now? Can you see it properly now?
Yes, it is.
Great.
Yeah.
Thank you so very much. So I'm Kamal Gulati from All India Institute of Medical Sciences, New Delhi, and we are a medical school. We claim to be the #1 in our country. We have a patient load of say 20,000 outpatient visiting us every day, and they come from all socio-economic status, all educational background, and they come from across the country or even neighboring country in the Southeast Asia, if I say. So, so we are very keen to know that how AI can help us in reducing our workload when it comes to our clinicians, our nurses, our technicians, and particularly medical records. So we are still in the hybrid mode. Some of our records are on paper, some of our records are in digital mode. And last year we had a cyber attack kind of thing when our data was there was a threat. So we also faced this sort of problem. So I think much of the things I've already spoken about, the AI, ethics, security, uncertainty, jobs, burnout, and everything. So a little bit of context when we talk about this study from the India perspective, because we are like the world's most populous country, so we are a country of 1.5 billion people, which is equivalent to almost all the Americas and the European Union combined. We have a democratic system, almost all religions, a very diverse and dynamic country. Diverse in the sense that there are remote areas like hilly areas. Pallavi also comes from Jammu, I believe, and that is again a remote area. So telemedicine AI can surely play a critical role when it comes to accessibility or availability of the healthcare consultancy. And we have seen during the COVID that the virtual OPDs or virtual were very effective for the patients who were unable to travel or because of the restrictions due to the pandemic. We recently hosted the AI Impact Summit in 2026, and Julie was here with us in New Delhi. So this shows the commitment of our government about introducing the AI in the entire, not only the healthcare system, but in the entire economical, social, as well as the educational space when it comes to AI. Government is very committed when we talk about the National Digital Mission, which is a patient-centric or the citizen-centric, which involves the central government, state governments, program managers, hospitals, clinics at all levels, and the labs and the health tech companies, insurance as well. India is committed for the national strategy for artificial intelligence, and we have introduced a new policy document, which is again a strategy for artificial intelligence in healthcare in February 2026 during the AI Impact Summit. Now, the irony is that the India's population, about 66%, lives in the rural areas. However, the percentage of doctors who are serving in the rural areas are 33%. So if you look at the two figures on the left side of the screen, so 66 people living in the rural areas and 67% doctors serving in the urban area. So I think this is a contrast where AI can surely play a role when we talk about accessibility of the healthcare at a cheaper rate, So economics is also a very important aspect of the healthcare so that people can afford. So we are still a low and middle income country where people don't have, so there's a stark contrast when it comes to socioeconomic status. So this figure shows the distribution of healthcare workers across states. So if we look at the Kerala, thankfully, luckily, I am sitting in Kerala right now. I am in the capital. So I'm taking this call from here, and I've seen that the doctors, nurses, technicians, and allied healthcare professionals working in the state of Kerala is like the best in the country, and the next comes the Delhi, which is the capital. But if you look at the lowest part, the Bihar, Jharkhand, and Odisha, which are not that equipped when we talk about the healthcare workforce, are possibly the worst regions in our country. So there's a huge mismatch between the healthcare workers which are available, and they are mostly concentrated in the urban areas. We also looked at, I would also like to refer this graph, which shows the gender distribution of healthcare workforce, and about 70 to 80% workforce are men. The only exception is nurses, where 80% of our nurses are from the women workforce. So this is again an interesting. So coming to the review of literature, we looked at some paper which are recently published in 2025. Not many papers are available when we talk about the Indian context, but these were like I found useful. The Samajhdar et al. 2025 says that AI is framed as a potential solution to long-standing gaps in service delivery and accessibility. And this is very, very important when we talk about the Indian context. Vishwakarma says that AI can enhance clinical performance through improved diagnostic accuracy, predictive analytics, and the personalized care pathways. Coker says that the AI-enabled tools are expected to shift the healthcare delivery from reactive to proactive models by facilitating early disease detection and continuous monitoring. AI can support public health surveillance, which is again very important in the Indian context because we are a huge country, and program implementation. So these are some of the articles which are published, which shows a positive side of the AI, how it can be an effective tool when it comes to delivery of healthcare services in a context like India. Somehow it is not going to the next slide. Oh, sorry. Yeah. The another paper by Nasir et al. Says that AI systems may disrupt traditional patient-provider relationships and challenge established norms of clinical autonomy and trust. So trust is the key word here, and we have seen in our hospital where the people are coming from all corners of the country that people want to meet the clinician in person. They want to have a personal conversation. They want to feel that touch, and this applies not only to the patients but also to the clinicians. They would also love to speak to their patients in person. They want to feel the energy. They want to talk to them. They want to understand about the entire uh, problem story which they are facing when it comes to their healthcare, as well as the social part of it. Vanamali says that the healthcare workers' positive attitudes towards AI, but also reveals substantial gaps in knowledge, technical competence, and competence. And I think this is like one of the major part of our study as well, because we are also trying to understand, okay, what are the attitudes of our healthcare workers when we talk about the AI, how receptive they are. Are they ready to gain some knowledge about AI and how it is going to improve their technical competence? There's many data related issues which we have talked about, like unbiased data sets, lack of interoperability are consistently identified as a major barrier. So Vishwarma very rightly point out that there's a need for integrated frameworks that account for the practices and outcomes associated with AI adoption, thereby providing a structured approach for both research and implementation. So these are some of the studies. So my research, along with Julie Davis, have shown that there's a need for leadership development amongst the healthcare professionals, particularly clinicians in India. There are gaps. So physicians, we found that the physicians who had some formal management training found to be more competent, particularly hospital administrators, and those physicians which have an experience of more than 3.5 years reported better leadership skills. But AI was not part of this study. But this shows that the appetite for the leadership development when we talk about the healthcare leadership development in the Indian context. Our recent paper published in Leadership in Health Services, and Julie is a co-author in this. There's a call for transforming physicians as administrators into professional hybrid medical leaders. And when we talk about the professional hybrid medical leaders, I think AI can surely play a role when enhancing their leadership competences. Coming to the gender, we have seen that when we talk about the women in leadership roles, about 16 to 18% women in India reach to the leadership roles in the Indian context. So this is again a very important possibly lens which we'll look forward to having in our findings of the paper. So we know about the AI and robotics. There are many concerns when we talk about the Indian clinicians or the healthcare workforce, increasing workloads, emotional issues, moral distress, and the mental health challenges which we are talking about, which leads to burnout at all levels in the healthcare workforce, right from physicians to nurses and allied healthcare professionals. So these are the possible threats to healthcare quality and the patient safety, which are again a very important components of healthcare system delivery. There are many concerns and challenges like increasing workplace surveillance and the creating job insecurity, uncertainty, as Pallavi very rightly said. But risks are higher when the AI is implemented without workforce engagement. So I think that we should involve workforce at all levels. And in this study, we are primarily focusing on clinicians and nurses, which are like the frontline workers, and of course, ethical issues, and there's a need to provide them adequate training and support when AI is to be implemented in the healthcare system. So the key points which I would like to hear is that AI can surely transform the healthcare delivery. Technology must support, but it should not replace the human care. The future healthcare systems must be inclusive and sustainable, and leadership should integrate ethics, innovation, and compassion. Thank you very much.
Great, thank you. Any questions before we move on to the final one, England? If you can stop sharing. Yeah. Okay, all right, just round off with, yes, go ahead, John.
Just a quick comment in terms of, I guess, age and profile is also going to be important, as well as experience of AI. So certainly a younger population, if I can call it that, those that are 20 years or just coming out of education. And that would be interesting to see from an India perspective too, how much those digital natives are effectively and their attitude towards it.
Yeah, I completely agree with you, John. I think this is something which is in my mind, that when we are going to include our sample, so what age group we should focus to. If you're talking to our, the young faculty members who have recently completed their medical degree and coming into the healthcare profession, so their knowledge, attitude, and competence will be entirely different from the professors who are, who have already served the hospitals for the last 30 years. They have been in profession. So it's a very small example which I quote when I speak to my colleagues here, that once you are carrying an iPhone, so those who are in the age bracket of 55 plus in India, I'm saying, they possibly don't know what are all the uses of the iPhone. They can just check their email, they can do WhatsApp, they can make phone calls. So you have very rightly pointed out that age and the number of years they have spent in the healthcare profession will surely have a great impact to our findings. So that's a very important observation. I appreciate it. Thanks.
Great. Okay, thank you. So just a couple more slides before we finish. So in the UK context, when we were fighting yesterday about whether we were having a current prime minister or not, the King made a speech in Parliament, and as part of the NHS modernisation bill. So this part of this the speech was about a single patient record. So in law now, as part of this modernisation bill, each patient will have a single record that joins up their health and social care. And this will be on the NHS app, and they're going to kick off with maternity and frailty care by 2028 and then roll it out further. So clearly these things are very dynamic. And in the 10-year plan, the idea is that allegedly, every nurse and doctor will have like their own AI assistant, a trusted assistant, according to the plan. And also the plan is to make the NHS the most AI-enabled care system in the world. So it'll be interesting to see whether that actually happens. And then the contrast is the regulator, the CQC, Quality Care Commission, saying that AI is not recommended where it can influence clinical decision-making, and talks about current legislation. So we are, as I mentioned, going through this MHRA regulator consultation process, and realizing that the legislation tends to apply to medical devices and not to AI. So I guess that's a regulatory issue. And then we have the practical issues of developing AI literacy, developing people's critical skills. As you said, these digital natives may be far ahead of the 50-year-olds without iPhones in India, but do they have the critical capabilities to deal with things when systems collapse and they don't have any technology or Wi-Fi? And how do you communicate with patients who may actually have more knowledge than you? So as I mentioned earlier, this Health Foundation survey looked at what patients are thinking and what practitioners are thinking, and concluded that we should be cautiously optimistic. And there are all these policies happening at the government level, but maybe not so much in specific organizations. As you said, Stephen, practice is ahead of policy. And these kind of guidelines to anyone working in the public sector in the UK on how to use AI. So knowing its limitations, using it lawfully, securely, having meaningful human control, not yielding control totally, and being collaborative, and understanding the commercial aspects, the drivers for these, and having quality assurance processes in place. And I just wanted to end on a positive story. So Great Ormond Street is given as an example as a use case, and it was rolled out in general practice and mental health beyond just Great Ormond Street. And the findings showed that use of ambient voice technology, AVT, increased patient interaction time 23.5% by 23.5% during appointments, which is a very positive story. And this was used by ambulance teams in hospitals, GP practices, and in mental health. So there's some positive evidence that AI scribing, at least, can be a transformative tool in these high-pressured environments. At least it reduces note-taking. And as I said earlier, we've added this question. Amar Rajan had a really interesting AI podcast with Reid Hoffman, who created LinkedIn, and his advice was, experiment with AI every day and in your personal life to build your confidence in your professional life too. But there is this issue always of safety and ethics that we have to be mindful of. Okay, those are our 110 slides. So I think I'll stop sharing now and open it out for any more questions for the next 8 minutes, if there are
I'm
any.
just going to say that, Julie, congratulations for, completing like 90 minutes and 110 slides. So
Apologies. Less is more, really, but anyhow.
So we've got some questions. I think we've got Peter. So Peter, you can go first and then we can move on to Apurva.
Yes, thank you everyone for presenting. I think the question that's in my mind, and given this is sponsored by UFHRD and UFHRD, is what kind of levels of training and development support this rollout of AI? Because that last example you gave there of the UK wanting to every nurse and doctor is to have an AI assistant with them, but it's only as good as if they know how to use these things. And again, I think we talk a lot of reasons for people's stress and burnout is they have these tools, but they don't know how to use them. So they feel under pressure and they feel under stress. And I'll give you one very, very minor example, which about 15, 16 years ago, I used to work as a training and development officer, and it was a regional role. And I was at an office in North Shields in Newcastle. And the area managers had all been given projectors to use with their teams and in their team meetings. And I walked into one office and this projector was covered in dust on the top of an office. And I said to them, do you use that for your team meetings? And the answer was no. And why was the answer no? Because nobody told us how to use it. And that was as simple as probably to everyone on this call of plugging the blue bits into the laptop and there it is, it works. So I just wonder if this kind of HRD and training and development kind of perspective is going to come into your study in terms of if we want to make AI successful, do we have the training programs and rollout to do that as well?
I think that's a really good question. We have this horrible mandatory training. I mean, I'm a trustee of a hospice and people do it by cheating. So you have like huge amounts of training, but everyone just looks at the answers on their chat GPT and they don't engage synapses in the process. So yeah, under usage is interesting. Yeah. And RHRD practitioners, because HRD is the first thing to go in recessions and so on, these specialists. Yeah, I remember visiting University of Toronto and in the medical school, they linked medical students with professors and consultants. So they had reverse mentoring. So they got the 18-year-olds to teach the physicians the tech and the physicians taught the kids life skills. So I thought that's an interesting grandfather model they had. John?
Just adding to that, I mean, that is the comment. I mean, the engineers would talk about first principles. So how are the generations going to develop and keep these first principles of whatever subject or topic that they're in, be it in healthcare or otherwise, rather than rely on, as I say, the AI tool to help them. And I guess part of that is also being able to understand how to ask the right questions and how that is informed. So I understand, I guess, your opening remarks about how do you draw your circle around the research that you're going to be doing, because it could well be, just about everything. And I think that's going to be quite a challenge in the first place.
Thank you. Damien, Naomi, anyone else on the call?
I think Apurva had it.
Oh yes, Apurva, go ahead. Yeah.
Just a casual observation, Professor Julie, and would like to know your thoughts. I know you have been traveling all over. Any specific reason why you have chosen and selected these specific countries? Because I saw some omissions, right? And when I read about it, some people say that the French system was best, or US. Typically, when I was part of a similar global, while we were doing a lot of things everywhere, the amount of revenue that was being generated is always significantly higher from a US perspective. So any specific reason why you have picked up the bunch of cohort that you have picked for this study and research?
Yeah, it's pretty arbitrary. I suppose I'm from a small country, Wales, and I remember someone saying it, like Estonia, it's very easy to manage a country like that. You can almost have everybody on a spreadsheet. So if people say, Switzerland, Singapore, they're the ideals, allegedly. So actually, what exactly is going on in these so-called beautiful nation states when everybody knows their name, like Norway and New Zealand. But yeah, interesting. US is the insurance model. And I was in Seattle recently, and one of our relatives is a palliative care physician. And he was remotely with 3 telephones, a Starlink. And it was interesting to see how technology was influencing his life as a physician, and constantly putting on his car on cruise control, and Amazon and Bezos, these people coming from that part of the world, actually. So yeah, it might be interesting to see what is going on in the US. I guess, a lot of literature doesn't look at the global South. It doesn't look at emerging economies. So we can justify from that sense. It's, a lot of the literature is just Western centric.
Yeah.
But yeah, we need to build up our case for that. Yeah.
Makes sense.
Damien, would you like to add anything? I can see you there.
Yeah, no, I think there's so many interesting dimensions to this. I think came through all the different presentations. I guess a little bit like John there, I'd be worried how far the investigation could extend, and I was wondering if you'd had any work on narrowing down some research questions to try and determine what would be out of scope, and just to make this, to ensure that you remain focused. Is that something which you've been working on?
Yeah, we have about 10 questions, maybe critical incidents, or we're going to have to, we have piloted the questions with some colleague in Bahrain. So yeah, I really appreciate that. I mean, most of my life I've been a practitioner, not an academic. So yeah, we're going to have to be really strict with ourselves about just that narrow focus. Yeah.
I think just as a little reflection on what you've presented, I think the model presented at the start and that question of demands resources is probably
we'll stick with that.
The best thing I saw was as a kind of unifying concept which could pull together a lot of this work. So that seemed to be a good starting point. But then, as you pointed out, there are things you would need to extend that model to take into account broader aspects of context and so on. But you're in a perfect position to do this because of the comparative nature of the work you're doing. So, yeah, that was my reflection.
Maybe JDR and culture or something, and just stop there. Or and we'll just have to be really strict. Yeah. Great. So time is up. So Palvi, I'll move over to you for a wrap up. Thank you.
All right. So yeah, thank you so much, everyone, for attending and actively participating in the session. I would really like to extend my sincere thanks to the panel members for sharing their valuable insights, their expertise and contributions throughout the discussion. A big thanks to all of you, the participants who took time out to, out of their busy schedule to be with us today. We will keep you posted of our upcoming webinars and keep you busy with useful conversations. And yes, keep you updated about, where we are heading as a forum, the University Forum for HRD. And we are all there as a community of researchers and academics and practitioners. And if you're interested in knowing more about joining the UFHRD, please feel free to reach us out. Thank you so much.
Thank you, Palvi.
Thank you.
Thank you.
Bye-bye.
Cheers, everyone.
Thank you. Bye, everyone.
Bye-bye.
Bye.